We are going to work through some substance abuse training today. And again, bear with me, my voice is also kind of going on me a little bit. So we're going to try to work together on this a little bit. So I wanted to just kind of start out a little bit and talk about where we're at across the nation. In particular, we're going to talk a little bit about substance use across the board, but I want to spend a lot of time today talking about adolescents and substance abuse because that's our population, right? So we're going to start today by talking a little bit about just where we fall in numbers. So I was able to find this really nice graphic that shows us a little bit about where we fall in comparison. And you can see that we're here about 3.5% about with illicit drug use with adolescents. So it kind of puts us in the middle of the board. We're not at the bottom. We're not at the top with some of the others that are out here in the 6th percentile. But we're definitely in the middle of the mix that's there. And I think that that's kind of interesting because a lot of times, you know, where do you think of a lot of the substance abuse being at? When you think of illicit drugs, when you think of heavy drugs, where do you think about that being at?
The cartel.
Okay. Ashley, where do you think about the cartel being?
Mexico.
Okay. So you think about it coming in from out of the country. Where else about the rest of you guys do you think about drugs being? Heavy drugs?
I usually think cities, big cities.
Right. We do tend to think big cities, don't we? Because we think of that as, sometimes we think of that as ports of entry. We think of that as being where there is a lot of the money and where things come in at. There's also more people, there's more customers, right? I tend to think about the coasts in general because kind of in that same vein, I think that Ashley was going, you know, again, ports of entry where things can come in at. So I tend to think about the coasts, and you can see some of the heavier numbers here on the West Coast, right? So we've got some bigger numbers, relatively speaking. But it's interesting over here, we've got some of the 2s that are here. We've also got the 6.2 in DC, but we've also got some of the lower numbers that are there. So why do you think that we start to get into some of the darker blues in the middle of the country? What do you think might contribute to that? I'm curious what your thoughts are on that.
Yeah, I think Midwest, because there's not a lot to do. There's more to do in the city. There's less to do in rural. And I don't know, I just think it's easier to push your drugs or users in the Midwest.
Okay. So boredom, I want you guys to keep that in mind. We're going to talk about some of the common reasons as we go through. I also want you to think about some of our kids, right? Some of the things that they encounter and just the things that they talk about, you know, because you know, like LaShawn is talking about, there's not anything to do. My kids talked all the time about there's nothing to do. That's just a common teenage thing in general. But kids have a 10-second attention span, it seems like, right? So, and in today's society, you know, we've always, adolescents have had a need for more immediate gratification than adults do, but now more than ever, because we live in a TikTok society, right? We live in an information bit society. We don't take things that take time. We take things that have to be received immediately. So we get bored easily. And I think that is a big reason. We need something that has excitement to it. And so I think LaShawna's got onto something there. If we just look at Indiana itself and some of the statistics, I thought some of these were interesting. We are 2.11% more likely, our teenagers are to have used drugs in the last month than the average American teen. So, you know, I mean, that says something there. And maybe, again, that has something to do with our being more rural and less to do that's here. When you look down through some of these, there's also some positives, though, in here. When you start to look at the drop in some of the other pieces, which is, I think, what we would expect. You know, it's more difficult to have access to the much harder drugs for some, not for all, because of environment, right? We have some of the pieces like marijuana 89% report using marijuana in the last month. So this is one of the most commonly used or abused drugs in the adolescent population in Indiana. Probably one of the easiest for them to access. And then as you look at some of the drugs like methamphetamine, cocaine, these and heroin, those percentages drop way below 1%. So I think that, when we look at that, at least we have that going for us. I think some of those statistics might look different in some of the larger cities. One of the other things, though, if you start to compare these numbers like cocaine, methamphetamine, heroin, one of the numbers that does go up, though, is the report of misusing pain relievers. So having access to grandma's Loratabs or Percocets, that type of thing, that is something that they can have more easy access to, or dads or moms or whoever's. So that number goes up a little bit higher. And so we see more of that's there. Alcohol is also a little easier for them to have access to. It's not legal for them, but in their environment, it tends to be more readily accessible. So this number is higher. 18 to 25-year-olds. This is also, our young adults. And so we're also looking at higher numbers here. So they are 7% are more likely to have used drugs than the average American. So we're still also looking at higher numbers there. So, our teens and young adults in Indiana in general are struggling more than some of the rest of the country. And it's something for us to be aware of and to take note of. And because we're aware of that, we need to also take time to look at how we feel as providers about working with people with addictions, with substance abuse concerns and issues, because there's been such a stigma around it for so many years. And it's really important to take a look at the fact that, almost every community that we have in our entire state has been touched by substance use, and not just the use and the abuse, but also overdose deaths. And those have been on the rise in the last couple of years. So we're really likely to know somebody that has been impacted by it. 1 in 12 of us have been touched by somebody that has been connected to addiction or has a substance use disorder. So what's really interesting, though, the statistic on the side, 4.2 million people who really felt like they needed treatment didn't seek it because of the negative attitudes that are attached to it. Working in treatment facilities in the past, there's a big deal about, having to be parked in front of a treatment facility and how people feel about that. I hate the thought of being there. If somebody drives by and sees my car there, what are they going to think? Or, I can't have my boss know that I'm going for treatment, that I could potentially get fired. There is a lot of stigma that keeps people away from treatment. So we really need to work on opening that up and making that just like any other illness, because it is a disease. We're going to talk about that a little bit more. We're going to talk about laying some groundwork for the understanding and terminology. And looking at it across the board, it really wasn't addressed as a disease or from a medical standpoint until the 80s. And if you think about that, that's pretty late in the game. Then in the 2000s is when it was actually looked at as a brain disorder. And really over the last, I would say since the 2000s, we're learning so much about neuropsychiatry and neuropsychology that it's amazing to see the differences that we are seeing and the progress that we're making, not only in addiction, but in psychiatry in general. So we're seeing progress there. And we are seeing it now classified as a brain disorder. Now we've got, 500,000 Hoosiers that are struggling with substance use disorder. So we're going to talk about a couple of different terms, and it's important to be familiar with the different terms because it changes the treatment depending on what the terms are that are there. The first one we're going to talk about is just substance misuse. When we're looking at substance misuse, we're looking at when we're taking a prescription, we have a prescription, and or alcohol. We could also be talking about alcohol, and we're taking it incorrectly. So we're talking about, I may take a little bit too much of it. I may take it, I may stop taking it too soon. And that happens a lot, actually. And I don't think people think of that as misuse. But when somebody just decides I'm done and stops taking it, that can be misused just as much as somebody that is taking too much of their medicine and finishes it before they should and needs their refills before they should. And so basically, any time that we are taking our medicine that's not consistent, if you pull your back at work and somebody offers you, again, grandma offers you a Loratab that they have in the cabinet so you can make it through your next couple of shifts, right? That's still misuse. Even if you only take one or two of them, it's still misuse. And I think that's something to keep in mind, because a lot of people will do that. Your partner has a couple from, having her tooth removed or having a root canal, and she offers you one when that happens. It's still misuse, and we need to keep that in mind. Couple of other things: incorrect dose, taking it the wrong time, forgetting it. Forgetting it is a big one too. We don't really think about that. It's not intentional misuse, but if that happens often, think about the concept. If you have something that you're supposed to be taking 3 times a day, that's hard sometimes when you're at work to take that middle of the day dose. So that can be a difficult one. Taking it for the wrong reasons and taking somebody else's meds. So the last one, taking it to avoid reality. I need to just kind of check out for the day. I need a couple of glasses of wine. It's been a really hard day. I've got to unwind. That's also misuse, having a glass with dinner because that's your drink with dinner is one thing. Having it for the intention of unwinding is a different story. So we move from misuse to abuse. And so when we're looking at that, we're looking at the fact that this is when we actually start using it with the purpose of getting high. There's the desire. We usually are looking at somebody that is struggling. They have a desire for something to be different. They may want to cut down, but they can't. They're starting to show patterns of problems in their life. They've got a lot of time and effort that's spent into trying to obtain the substance, whatever that is. Maybe I've used all of my prescription for the month, and now I'm trying to figure out how I can get more of it and where I can do that. Maybe cravings will become a part of substance abuse. There's no if, it will, and there's no question about it. And it starts to cause problems in your life as well, and you start to see that. So there's problems in your social life, problems in your employment, problems in your personal life, as well as work and school. So we could be looking at things like, it could be as simple as, I've already gotten in trouble, maybe had a DUI, maybe had to take some classes, but I'm still I had one margarita at Hacienda and I'm still driving home that night. Or maybe I lose my job after coming in late too many times because I only drink at home. It's not a problem. I only drink at home, but I have trouble getting up the next morning and getting to work. Or there's a lot of fighting that's going on in the home because because I did get fired because I lost my job, or I'm not carrying my share of the load at home. And it's all connected to that. So those are the kind of problems that can result from substance use and from substance abuse. Then the next step, if you're kind of looking at it like a continuum, is when it turns into dependence. And dependence is when we're looking at things have become, it's a physiological piece now. So it's no longer just psychological, it's now psychological and physiological. My body is dependent on this substance. And without it, I start to become ill. So I've got an increased tolerance, or I have to have more and more substances to get the same result. And eventually I'll have to have more and more substances just to feel normal. Some of those, it's really important to have an appreciation for those substances and what's going on, because sometimes people don't even have an awareness of how this is building up for them. And, you know, the families are talking to them, and the families desperately want them to quit. And it's important for them to understand that some substances, it's dangerous for them to quit cold turkey, to quit suddenly, because it can cause some damaging side effects of its own. Some substances can cause seizures. Alcohol, for example, is one of the most dangerous drugs to quit cold turkey. If somebody, depending on the length of time and the amount of the drug or alcohol that somebody has been consuming, somebody could go into the DTs, and that can be very dangerous for somebody. Opiates and opioids are also, they're one of the most uncomfortable withdrawals that there are, but they can also have their own dangers during withdrawal. We used to actually use those three categories, and we used those in our diagnosis. When our last DSM came out, which is our diagnostic manual, there were changes. And so instead of having a diagnosis of substance abuse or substance dependence, now everything is called substance use disorder. And so it's considered just a continuum. And so now we look at it like you're on a substance use continuum. So you have cannabis use disorder, or you have alcohol use disorder, or you have opioid use disorder. And then you have to have what's called a specifier at the end of it. So you either will have alcohol use disorder mild, or moderate, or severe. So we looked at the concept of the abuse or the dependence. Now we use a specifier for mild, moderate, and severe. It's important to know those terms, because those terms are part of what we are looking at when we are looking at some of these criteria in the mild and moderate and severe when we make diagnoses. But for the diagnosis now, you may not see those terms like you used to. For mild, somebody has to have 2 to 3 criteria. Moderate, they have to have 4 to 5. And severe, they have to have 6 or more criteria. And then there are 2 other criteria. One of those is called in a controlled environment. So that would be something like somebody that is in a treatment facility, in a residential facility, in a jail, something along those, but some type of a controlled environment where they do not or should not have access to those illegal substances, or substances that they should not have at that point in time. The other, the last specifier is called on maintenance therapy. So you may have somebody that is on methadone or Suboxone. And so that would be that type of a specifier. They would be on a maintenance therapy that they are utilizing to help them through withdrawals so that they can manage those really uncomfortable symptoms that are there. Just to kind of look at like a thought experiment. I don't know how many of you are familiar with this concept, and this is a really light picture. I really wanted it to be darker, and no matter what I did, I couldn't get it as dark as I wanted it to be. Maslow's hierarchy of needs, you know, the concept that we can't really move up to deal with our next level of needs until we've addressed the first level. So we have physiological needs, and then we deal with our safety needs, and then we deal with our love and belongingness, and then we deal with our esteem, and finally we deal with all of our self-actualization. It's really interesting though, because once you throw addiction into it, it just shatters all of that. And it splits it right into, think about the concept of, if you were to sit down right now and make a mental list, or if you've got paper in front of you, list the things that you think are most important to you in your life right now for a healthy, happy human life. What would that sound like? LaShawna, what are a couple of things that are important for a healthy, happy human life?
For me,
Anybody, for you, for the kids we work with, just what do you think in general are important for a healthy, happy human life?
to be stress-free,
Okay.
no worries,
Okay.
to be
Gotcha.
healthy.
Okay.
And then I guess what would that look like? But yeah, just to really, I don't know. I can answer that in so many different ways. Sorry.
That's okay. That's okay.
They enough food, knowing you have shelter, heat. Heat now that it's starting to get cold.
Yeah, I guess just having your needs met. And that is very true.
Great.
If those needs are met, I tend to have less worries.
Right. Tamara, how about you? What would you throw in there? Oh, we can't hear you. Are you on mute?
Okay. Support.
Okay. Absolutely.
Support. Just support and someone to encourage. Socialize with healthy individuals. So.
Gotcha. Gwen, I can see your face. Sorry, you happen to be at the top of the page. Let's focus on that healthy part. What is another couple of things you think that you would have to have for the healthy part? You're on mute too.
Honestly, I don't know. A lot of the main things were pretty much said. For me personally, for like a healthy life, because I have Crohn's, I have to like follow like a certain thing and having like a certain structure. So like having that in place and having the knowledge for that stuff kind of like is like a healthy thing for me.
Those are really good. So having, structure, having some things in place for all of that. So, obviously there's no wrong answers for those kind of things, but, some things are concrete, right? Somebody said something about, a house and a way to stay warm and things like that. And a lot of you guys talked about some of those more abstract pieces, we need support and we need caring and those pieces that are there. So those are there. Consider, the attachments that any attachment that you think that you personally might have that could be addictive, anything. It could be a substance. I personally drink Coca-Cola every day. I have a little bit of a caffeine addiction, maybe a lot of a caffeine addiction. Or it could be a relationship, or it can be a behavior. Some of us are, might be avid hikers or joggers, or, just can't get enough shopping, or, whatever it is, doesn't matter what it is. Could just be sweets. I like to bake and I like to eat what I bake. So there's that too. So consider something that you think of as some kind of something that is an addictive attachment that you have, anything at all. And put that at the top of your mental paper that you've got in your mind, okay? Just place it there at the top of your paper. And then all of those things that we were talking about earlier that we had on our list that we just came up with, all of those supportive relationships, all of, that healthy home. Looks like I got turned my phone off, sorry. So all of those things that we talked about earlier. Now picture yourself going through that list and that structure that Gwen talked about, all of that. Just picture yourself starting to cross each one of those one at a time. Go through Lashana's list. She had several supportive things on her list. Picture yourself crossing those off one at a time, because those are the things that get compromised with addiction. And again, we don't want to think about the stigma. We don't want to think about judgment in this, but I want you to think about how that feels. Just as a thought experiment, think about how that feels to mentally picture yourself crossing those things off. When people in treatment, complete this exercise, they actually end up crossing off almost everything off of their human goods list, right? And because they know what they've been through, because in their actual addiction, it's happened to them. They have sacrificed a lot of those relationships. They have lost housing. They have given up physical health because of their addiction. And a lot of that has ended up being secondary or falling off the chart based, compared to their addiction. The addiction came in just like this, and it just devastated everything else. I mean, it's just difficult to even imagine, but think about that for a second, what that would feel like. So it's really, when we think about addiction, I want you guys to think about it as a disease of our motivational system, because it comes in and it totally attacks our motivational system. We become so attached to the substance, the relationship, the behavior, because remember, we can also have those addictions, process addictions like to gambling. We can have process addictions to shopping. We can have process addictions to things like pornography. So all of those work very similarly in the brain. So to a substance, a relationship, a behavior, and our other priorities become compromised, and they become compromised for the sake of that addictive attachment. And that severity can be measured by the degree and the scope of the compromise. This definition is too nice to try to butcher it. So it's consistent with the definition of addiction of the American Society of ASAM, so addiction medicine. So I want you to really think about it like that, because sometimes I think we get really stuck in I can't believe that they would choose this over that. And it's not necessarily a choice so much as it comes in and it really hijacks our brain and our motivational system within our brain. So if we really look at it, addiction becomes chronic, compulsive, and relapsing. When we talk about chronic, obviously it's long-term, it's ongoing. And compulsive, it's something that becomes almost to the point where we can't control it, it controls us. And relapsing, meaning that it is cyclical. And we tend to see those patterns that happen. It doesn't mean that every single person has to relapse, but it means that it's important enough for us to expect those cycles so that we are aware. So that we're aware of it, and that we can be prepared to work with that person. I think that those things are really important when we're trying to maintain empathy. When you guys have been working with kiddos or family members of our kiddos that are struggling with addiction, what is the most difficult thing for you to maintain empathy? What's made it most difficult, or has it been difficult to maintain empathy when working with family or kids that struggle with addiction?
For
me,
me, oh, go ahead.
I was gonna say for me, it's way more hard to keep empathy when it comes to like the family. I think just because I see what it's doing to the kids that are here. So that's the hardest part for me.
Mm. Thank you, Chen. I think that's a really common thing for us.
I
Another-
agree. And seeing parents mistreat their children because of addiction.
Mhm. That's really hard when it comes up against our own values and ethics, right? Because even that word, mistreat their children, and because that really strongly screams of something that comes up and it rubs against my personal values. And a lot of times I think that's what we see, because especially working with children, all of us tend to have a value that says something about the way that we care about family and children. And that's a big part of the reason that we're here. And so when we see that, it's a challenge for a lot of us because of that. It doesn't mean that we don't recognize the struggles about addiction. It just means that it's, we recognize that struggle, and we have to work hard sometimes to, pull from our deep down from our resources to work at holding on to the empathy, because we know where it's at. And sometimes it's just difficult, and that's okay. Give yourself grace, right? When you're having those days and you just when you want to be human, right? And I know that there are times when I get a little bit on my high horse, but it is important that we're all human and we allow ourselves to be human, and to give ourselves grace when we are frustrated with a situation, because we need to have empathy for our clients and their families, but we also need to have empathy for ourselves when we're working with our clients. The work we do is difficult work. So, did anybody else have anything to add to that? I just think that's a really important topic. I think that's a piece to keep in mind, because I think it's a piece that helps us. Keeping that in mind helps us to prevent burnout. So all of that in mind, what are some of the behaviors or the symptoms that we could see when we are looking at teen substance abuse? Actually, let me go back. Let me ask you guys, before we even look at it, what are some of the things that you think of when you think of teen substance abuse? What do you expect to see?
I would say like inconsistency in like mood and behavior.
Okay, that's a good one.
A change in what they like to do or into. They stop being into certain things that they were before.
Okay.
And maybe like not attending school or work, like if they have a job, at least not consistently attending those.
Maybe a decrease in their relationships.
That's good.
Change in appearance.
One more time.
A change in appearance, like the way they look.
That's a good one, Justin.
Yeah, I was gonna say mood swings or mood behavior changes, whether they isolate or become aggressive or comatose. Some of them just sleep away. I don't know.
Yeah. You guys have got a lot of really good ones. Anybody got any others that maybe we haven't mentioned there?
I think sometimes they might be on the defensive side. Sometimes they get snappy. You try to talk with them.
That's a really good one. Was that, I was trying to see, I'm not sure, was that Netherlands? That was a really good one.
No, Tamika.
Tamika, okay.
Yes, ma'am.
I've only got the little side strip, so I can't tell and there's only a few faces that show up and the rest of them are way down on the bottom. So some of the pieces that we're looking at, and you guys talked about some of them, right? So there's changes in the behavior, and then also there's the physical changes. So if we start by just looking at some of the behavioral pieces, that avoidance is a big one. None of them wants to be cot, right? And they avoiding eye contact. Why do you think they would avoid eye contact? Why do I not want you to look at my eyes if I'm using?
Because you might look high.
How
Your
do you
eyes,
know if I look high, Chin?
like your eyes might be red or bloodshot, or your pupils are either smaller or more dilated.
Good, good. What am I on if my eyes are all bloodshot?
Usually they're smoking pot.
Reefer.
There you go.
Yeah.
What am I on if they are pinpoint? Likely. What am I likely on if they're pinpoint?
Is that more of like the uppers?
Actually, it's usually more like the opiates.
Okay.
So keep in mind, sometimes medications can have side effects too, but that usually tends to be that class of medication. What if they are like big as saucers?
Cocaine.
LSD.
Cocaine.
What'd you say, Justin?
Cocaine.
Oh, a lot of times too, I'll see, like if somebody's been smoking much, I'll also see them really big too. And so, but it's interesting just to see the changes, right? So what might be some other reasons other than just the physical appearance of my eyes? What am I trying to do?
It might be like ashamed.
Exactly. Exactly, Jessica. That's perfect. Ignoring rules, right? So things like breaking curfew, they're acting irresponsible. Under that irresponsibility, I would throw some of that disrespect that you guys were talking about in there and talking back. If that is a change in behavior, I would throw that in there. Those secretive calls, locking the bedroom doors because I don't want you to see what I got hidden in there, right? If you're looking and you're searching for stuff in my bedroom and I'm your 16-year-old, where are you going to be looking?
Everywhere.
That's the best answer.
That's what I was gonna say.
That is definitely the best answer. Kids are creative, and if they could use their power for good sometimes instead of evil, we wouldn't have a concern in the world about our future. They are really creative, and they sometimes they'll put them in the normal places, but I've seen them use some very creative places to put things too. When not necessarily kiddos, but when I worked at a residential treatment facility, people would try to put pills into the hem of blankets or the hem of their pants, different things like that. And I know you guys have seen some really creative things, because I love KF's story about the little girl who put the cell phone in her hair, in her bun. So they are really creative about where they will put things. Isolating is another big one. Making excuses, missing school, that's a big one. Loss of interest. So we talked about the physical changes. That poor hygiene is a big one. We talked about the eyes. So this is all the physical changes in the middle here. Changes in mood. I think Justin's the one that talked about that. How about the sores on their mouth? What might some of those sores be from? Any thoughts on that, guys?
At-risk behaviors for being under the influence, possibly.
Okay.
Burns, like pipe burns.
Yeah, I was gonna say a hot pipe.
Yep, they can be a pipe burn. If it's not a pipe burn, what else could it be?
Be from them picking.
Yeah, it can be from picking. Also, I've seen some kids that huff or that use the cans. I've seen some of those cans explode, and I've seen them get really like the cold burns too from those. And so it's interesting. Headaches, the rapid weight change. That's one. So the risk factors, and we'll talk a little bit more about this, but you're looking for the facts, right? So the family history, age of first use, this is a big one because the younger that they are, the more likely that an actual long-term problem will occur. Craving intolerance and surroundings. So the first letter of each of these reminds us that we're looking for the facts that are there. But I also want you to take a look at these two lists, because if you look at these, if any of you are very familiar with some of the behavioral health concerns, these lists look like some of those as well. So the mood changes, the poor appearance, the hygiene, the change in my behavior and locking myself away and isolation and withdrawal, even the headaches and the irritability. A lot of this can also look like some mental health disorders as well. So it's really important that we take a look at this closely to try to make sure that we can differentiate and see which one we're looking at. That's the next trick. Okay. This one is a video on how addiction affects the brain. And we're going to talk more in detail about it, but it's just a nice little 2-minute clip, and it does a good job of it. When I started, if you guys can just give me a thumbs up so I can know for sure that you are seeing it, I would appreciate that. Seeing it and hearing it.
Addiction and drugs such as alcohol, heroin, and cocaine often come to mind. But other substances like nicotine, marijuana, and prescription pain medications can also be addictive. So can certain activities such as gambling and sex. Whatever the case, addiction involves craving and a loss of control, with the substance use or activity continuing even if it causes harm. This can include problems with relationships, jobs, school, money, or your health. Addiction is not due to weakness or a lack of willpower. Instead, it's a chronic disease involving changes in the brain. There, billions of nerve cells, or neurons, communicate through a series of signals and chemical messengers. When messages leave one neuron, they attach to a receptor on the receiving one, like a key fitting into a lock. In addiction, this communication process is disrupted. Large amounts of a brain chemical called dopamine are released, overwhelming receptors and resulting in the high that people experience. To keep that feeling going, they take the drug or engage in the behavior again and again. Eventually, the brain changes and adapts, driving them to seek out more just to get the same feeling. That's called tolerance. Stopping a substance can cause withdrawal symptoms such as nausea, tremors, depression, or severe anxiety. Taking too much of a substance or a combination of substances can result in an overdose and serious illness, or even death. Young people are especially vulnerable to addiction. The impulse control center of their brains, known as the prefrontal cortex, isn't fully developed, making them more prone to risky behavior. And using substances can cause lasting harm to their developing brains. If you think your child might be experimenting with substances, talk to them about it. Parents can help by taking a strong stand against substance use and teaching their kids healthier ways to deal with life's stresses. Like any other disease, such as diabetes or asthma, addiction can be successfully treated. So if you or someone you know has a problem with addiction, talk to your doctor, a mental health professional, or an addiction specialist. Getting help may save a life.
So really, it's some of what we talked about, but I really wanted to get across the piece about the transition that's in there between the dopamine and how important that is. Dopamine plays a huge role in addiction, and our brain really wants a lot of that dopamine. When we are using substances, our brain begins to be flooded with that dopamine, and we are we're wanting more and more of that because it goes to our pleasure centers. So let me flip this back up here. Hold on. Okay. Yes. Please and thank you. No, it's not going to work. Of course it's not. Because that would be too simple. Mhm. Next time Jessica, next time Michelle needs technical assistance. So,
I always need it as well.
okay. Tell me what you guys do understand about the brain while I'm pulling this up. When you think about the brain, do you think about it as one large system, or do you think about it as having like compartments?
I think of it as having compartments, like there's a downstairs brain and there's an upstairs brain.
That's a nice way to put it. We actually a lot of times refer to it as a triune brain. So like there's kind of like 3 sections. And today we're going to talk about 2 of the major sections as soon as I can get this to pull up again. The current slide, that would be nice. Okay. Now, I don't suppose you guys can see what's on the screen yet, can you? Okay. So we're going to talk about, if you think about the brain as being primarily like your fist, the lower part would be the section that kind of keeps everything moving, that keeps us breathing, that takes care of all of that. The middle, if you have a closed fist with your thumb in the middle, that is the center where we would say is your limbic system. This is the older part of your brain. This is, in terms of evolution, this is the part that controls this controls survival. It controls and regulates. You guys can see the screen that's up there that says 2 primary systems, correct?
Yes.
Okay. And it talks about regulating appetite and emotions. But again, this is about survival, but it's also about our pleasure center. So this is where our immediate rewards are at. Remember that we were talking about adolescents earlier, really having a lot of need for immediate gratification. So they spend a lot of time in this center of the brain, in the limbic system. Trauma gets trapped in the center of the brain as well. But until we become around 12 or 13, all of us spend most of our time in this portion of our brain, because the upper parts of our brain, the executive system, where decision-making happens, planning and reasoning, where we set goals, where we do all of our logical thinking, that doesn't happen until we are in our early 20s. There we go. And so at that point, and that's when we really start to have that other section that becomes really involved. It takes both pieces of these to help us to work together and to make really great decisions. And when we work in DBT, we teach the kids about the emotion mind, and we teach them about the rational mind. So if you think about these 2, the emotion mind would be the limbic system, because this would be the piece that makes impulsive decisions, that makes emotional decisions. Decisions are all based out of emotions that are there. We're not really thinking through things. We're feeling our way through everything. And depending on, how far over we are on that continuum, we may be difficult for us to get back into any type of rational thinking. Over here on this side, on the rational side, we can be colder, we can be more distant. So it's nice to have some balance. And that's what we talk about a lot in DBT when we're using those skills. So when we bring those two together, we're always looking for the wise mind. And it's the way that we use a little bit of both. When I think about addictions work, I think about treatment and I think about the support system as kind of being the mediator and being that part that helps to play the wise mind. Because the person that is struggling with the addiction is having difficulty being able to connect these two parts together. It's like these two pieces aren't playing well in the sandbox together. They should be working together to help with motivation and with behavior. All of those things that we had on that list earlier that were struggles during addiction or behaviors that we might see that would be indicators for somebody struggling with addiction. These two pieces should be working together, but instead, a lot of times what we will see is that they are fighting one another. Because what happens is, since the limbic system is the one that's all about having a good time, because it's about emotions, it's about, hey, let's enjoy this, let's have a good time. Or it can also be about fear, let me fight back, because it's about safety and security too. Sometimes the executive system has to come in and say, hold on, let's look at this situation rationally and see, is this really a threat or not? Or hold on, let's make a decision. Do we really need that third beer, or do we really need that third drink or not? And so they should be working together for motivation and behavior. However, in our adolescence, because this part of their brain has not fully developed, typically in someone that has not experienced significant trauma, because significant trauma can delay the development. But if you haven't experienced significant trauma, this part of our brain that takes care of all of that rational decision making, it starts developing around 12 or 13. And for women, it's usually fully developed in our early 20s. For men, usually a few years later. So women 22, 24, men 24 to 26, someplace in there. So for our teenagers, they're not there yet. They're just kind of coming online. They're having difficulty, just getting, day-to-day stuff anyways. And then when you throw substances in the mix, that delays that more. And sometimes, some of the things that we talked about earlier is that substances can cause some negative impacts, such as it can actually cause a smaller prefrontal cortex. So it can actually cause this area of the brain, the development of it it can delay the development, and it can also reduce the development of it. So it's smaller. And so that's going to impact not only just decision-making, but in the long run, it also impacts learning, memory, and some other pieces that we can talk about later as well. Let's see. Also, addiction can play a lot into genetic factors. In the last several years, we've been learning more about epigenetics, which is we can actually have changes at a DNA level from trauma. If we are undergoing daily trauma, and we talk a lot when trauma work about big T trauma and little t trauma. Big T trauma would be huge events in our life, a death or a threat of death, something like 9/11, one huge event that happens to us, some type of a personal attack that happens, a rape, a huge car crash that kept us in the hospital for quite a while. Little T trauma is being in a household where I am beaten down, verbally daily, where there's a domestic violence that's going on daily, even if it doesn't happen to me, where there's just constant threat that's going on. So all of those little T's can add up to just as big of an effect as one big T. So that type of ongoing threat can make a change at a cellular level, at a DNA level, and it can make lasting impacts. And I can pass that on to my future generations as well. So we talked earlier about those. We talked about the behavioral changes. We talked about the physical changes. And then we talked about those pieces of the facts. We talked about, the families, and we talked about some of the other pieces that were there. And one of those or that we will talk about is at a genetic level. So we're talking about things that can be passed on to us from our families. And that's important for us to think about, because there are certain genetic predispositions for some folks to develop an addiction over other folks. So I wanted to talk a little bit about this piece. So you will hear some people talk sometimes about they're chasing that first high. And then also you'll hear the family members saying, I just don't understand it. And this graph I wanted to use to talk about that a little bit. So I want you to first look at this bottom line. This bottom line represents the neurotransmitters. So all those things like the dopamine, the norepinephrine, and our serotonin levels. So all those neurotransmitters that are in our brains, right? So this is representing those levels for somebody that is predisposed to addiction. Somebody that has the family genetic level that's there. Oftentimes what we find is those folks that are predisposed to addiction start their life with a lower level of those neurotransmitters in their brain to begin with before they ever start using. This second line represents folks that don't struggle with addiction, okay? And this is where they start out. So this represents the level of neurotransmitters in their brain when they start out. So two people go to college, okay, same time, same age, all right? And, this is where Tiny Tim starts at down here. And this is where Susie Q starts at up here, okay? And they decide that they are, they're going to smoke some weed, and they're going to have, at the party, and everybody's drinking that night too. And it's the first time either one of them has smoked. So the interesting thing is, they both, it's the very first time either one of them has smoked. And this yellow line, this yellow curve, this represents Susie Q. So for her, she smokes, she gets her buzz on. So this is her. So from where she started to where she got to that night, this is her high. So she has this nice little amount here that we're talking about. Okay. However, Tiny Tim, look at the difference. So this is Tiny Tim's first time smoking too. So when he smoked that night, he went from here back, Michelle. He went from here all the way up to here. Look at the difference in the height that they went. So if I had numbers on the side, which I didn't put numbers over there, but let's just say this is about 1 inch and Tiny Tim's is about 2.5 inches. That's a big difference. Okay. So that's the reward that Susie Q got, was like, oh, this is okay. This is kind of cool. But it's nothing compared to Tiny Tim, because Tiny Tim started out at like, Tiny Tim started out as Eeyore, oh, well, blah, 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 and all of a sudden by the end of the night, he was Tigger. Okay. That's how big of a difference that was for him. That's the difference that he felt based on how big of a jump that was in the neurotransmitters and the dopamine in his brain. So that was his first high. And then these other blue lines represent the next, over the several months, up to a year or two, that he continues using. And he probably decides to try some different drugs or drinking a lot more. And what this represents is tolerance for him over time, because he never quite gets that same feeling or that same high and he continues to use. And what's happening is, it doesn't go as high the next time that he uses. And the next time it doesn't go quite as high as that. And eventually it gets to the point where when he is using that same amount, he's not even quite getting up to where, he's not even quite getting up to where he was before he ever used it all. So now he's way down here. And so now he's like, I'm either going to have to use a lot higher amount, or I'm going to have to switch to a new drug to get a better high, to start feeling normal again. So when we talked earlier about sometimes I just have to keep using more and more until I feel normal, that's what all of this represents. So what this also represents is the fact that when the family members, when we're sitting around in treatment groups and when we've got family education groups and we're sitting around with those family members and they're like, I just don't understand why they give up everything. I just don't understand why they won't make their kids more important. You don't understand, Susie Q, because you never, you didn't start the same place that Tiny Tim did, or Mama Susie Q may actually say, I smoked a little weed in college and it never bothered me. I don't understand why he just can't quit, and I've heard that before. This is why, because not everybody starts at the same place. And I think this is a really interesting piece. Do you guys have any thoughts or questions on that? Or does it make sense to you? I'm going to take that as a yes. Okay. So looking at all of that, and when we put it together, there are 3 stages of use. People start out with use, and they're using to feel high, they're enjoying it, or maybe just to feel relaxed, even escaping, but they're using it. And then they get to that spot where it's extinguishing, like we were talking about, where he's just to that spot where he's just trying to use to feel normal, and he's just not getting that high anymore. He's starting to withdraw because he's not getting that same amount in there. And then he gets the cravings. So it's use, withdrawal, and craving. So that is the stages that people go through. So I want us to kind of move into talking a little bit about withdrawal and detox then. So I want us to talk about this side of things. What do you guys know so far about withdrawal?
It's hard sometimes.
Is that
the alcohol? Yeah.
Oh, go ahead.
The alcohol is the hardest to withdraw from, or the most dangerous.
Okay. And why is that, KF?
The risk of death.
Mm-hmm. Yeah. Because
you never stop craving. I think it lessens, right?
Yeah.
It's always in the back of your mind, or
yeah,
everything reminds you, things that remind you, friends that they'll always remind you.
I think you learn to deal with your triggers better is what happens over time. I think you replace some of the behaviors with other things. And I think you learn to deal with the triggers a little bit differently. But yeah, I mean, that is still there. And if you constantly expose yourself to those triggers, you're constantly at risk. So those are all good things. Anything else?
So it's true that alcohol is the hardest, because I thought it was like opioids and heroin that was the hardest to withdraw from.
Alcohol is the most dangerous because of the physiological risk, like KF said, the physiological risk of death from that. But opiates it is the most uncomfortable. And then as a result, people tend to give up quickly and go out and use again. One of the scariest things with opiates is if I use and I go through withdrawal and I detox and I get clean and I stay clean for a little bit, and then my life crashes down around me. I go through a divorce, I lose a job, whatever, right? I go out and I use again. If I go out, a lot of times people will go out and use the same amount that they were using when they quit the last time. That's really dangerous because they had built up tolerance to where they were at when they quit the last time. So if there's been a decent amount of time in between the last time they used and now, that dose that they, if they stopped at however much and now they started with that same amount, it could potentially be an overdose for them now, where they used to be able to handle it because their system is not used to it the way it used to be. So that's very dangerous. But the actual detox and withdrawal period itself, alcohol is more dangerous. Opiates are more uncomfortable. Alcohol is more dangerous because of the seizures and the risk of death during that. So if we look at this, what's happening during it is your brain is telling your body, saying, I need this in order to feel normal, because it's not getting that same rush of dopamine that we were looking at that video earlier. And so what tends to happen is withdrawal will begin anywhere from 8 to 24 hours after you've last taken drugs. And some of that depends on what drugs that you're using. It also depends on how often and how heavily you are using those drugs. So some more so than others. And when you are going through withdrawal, that can go anywhere from a couple of days to a few weeks. And it's interesting to see how the withdrawal looks too. When you see somebody come in, Ashley, you were at Brentwood. Were you on, I never have asked you this, were you on the substance abuse side, or were you on the mental wellness side?
They had actually merged both.
Okay.
So they were both on each side.
Were you on inpatient though?
I actually had the opportunity to do every department. So I got to see outpatient and inpatient.
When somebody's going through, if you have a few patients on an inpatient unit that's going through withdrawal for opiates, it's like having the flu, and it's like having the worst flu ever, and it's not a pretty thing, and it's rough. I mean, it's really rough to see them have to go through that. And they don't sleep because they ache and they hurt so bad, and they are sick, and it's, sick from both ends. So it's a really rough thing. Somebody that has been on a meth high for a week or two, and then they come in, they usually crash for about the first 3 days. So they do nothing but sleep. We don't see them for a few days after they come in. So that's an interesting way to see that go through too. It's just interesting to see the different ways that things happen. A lot of times when people can come into a facility, a medical facility, they can do medical detox. And with medical detox, they will use medications to help ease the symptoms. So they can utilize like anti-seizure medications to help. They can actually use some benzodiazepines in some of the detox regimens as well. They will taper them up and taper them off before they leave the hospital. And then there are, I mentioned earlier, some of the medications. So the medication assisted treatment. So things like the buprenorphine, the Subutex, methadone, those type of medications they will use with heroin and opiates to help people through their withdrawals. A lot of times they will continue those medications. I have pretty strong feelings on long-term use of those medications. And I have concerns about long-term usage. Many of those medications people will use on top of at times if they are struggling, because they can still get a high on top of that medication. So if they're taking their methadone or their Subutex, they can take another drug on top of that and still get a buzz. There are other drugs like naltrexone or the injectable form of that works on like alcohol and some other drugs that you can't get a high from. It's basically you're just wasting the money that you spent on the drugs. And that I think has a lot of benefit. So,
Can I ask a question?
yes.
Sorry, when you're talking about medically withdrawing and stuff. So I know someone who was given medications and stuff to like medically withdraw from home. And at what point does that become like dangerous or like a liability? Because I just feel like that could be unsafe.
Depends on what they were withdrawing from. Because you know, if it was a physician that, you know, gave them medications and told them to, you know, and was walking them through that again, and if they were honest with their doctor and said, you know, this is honestly how much I was taking and all of that, and if it was something that they were working with them on, you know, I would assume that the doctor had known them well enough to make those calls. And so that's kind of a blanket question that's really hard to answer, right? If they are very concerned about them, they almost always send them to the hospital. So I would, and this is a big assumption, but I would make the assumption that they had checked them out and weren't concerned about any life-threatening issues. They usually are looking at things like blood pressure and, you know, risk of seizures, those pieces that are there. So they don't want them having a stroke or a heart attack or, you know, seizures during that time. So they're trying to prevent those pieces. So I'm assuming that they probably checked them out if it was a medical prescriber. Does that help at all?
Yeah, kind of.
Kind of, I know. not knowing the case, not knowing the person, it's hard to say, but that's about as best I can do, is to tell you that, you know, in general, you know, and physicians are usually pretty cautious about liability. So I would also kind of look at it from that perspective. Okay. During this time, during withdrawal and detox, some of the other things that people struggle with, depression and anxiety, this is a big one, because remember, during the time that I'm using, I've had this huge flood of dopamine that's been in there, that's been making me feel great. And I've been up and I've been feeling wonderful. And so now all of a sudden, boom, it's like everybody just like shut the lights off and took all of that away. And my brain has not been creating it on its own, because the drugs have been coming in and saying, here, do this, because it's been telling it what to do. So now all of a sudden, it's going to take a while for my brain to start functioning the way that it should have before. So depression is a big thing after somebody decides to quit using. And it takes a while for everything to come back. Memory issues tend to, during withdrawal and early recovery, memory issues tend to be a large issue as well. Depending on what substance that you're going through, that long-term recovery for your brain can take a while. For instance, methamphetamine, once you've made it through withdrawal and you're into your recovery, it can take up to 12 months for your brain to actually heal from the use that you have been doing. And we're talking just to heal for your brain to actually function appropriately, for decision making, for memory, for all of those things, learning new things, and being able to store new information. So when people miss appointments, when people are having trouble in school, all of that is real, because they're having trouble due to a lot of what's happened to their brain during their use. So following up on the other side of that, if somebody does overdose, I wanted to talk about this a little bit. So signs of overdose, and this is becoming a larger issue across the country and definitely here in our community. You know, when signs of it, you know, we see somebody that's unconscious and they're not able to wake up. They have the real shallow breathing that's there, or maybe they've stopped breathing. You might hear that choking, that wet breathing sound that's there, gurgling that's there. And for the people that you just can't wake up, the blue lips that are there. Also the fingernail beds can be blue too. So you can see any of that that's there. If there is an opioid overdose that's suspected, you want to try to wake them up. You want to work on, you can work on trying to wake them up, kind of like the sternum rub that's there. If they're not breathing, before you would do any of that, you're going to call for 911. And then you can try to do some of this other that's here, monitor them. And if they don't respond, obviously, if they're not responding, then call 911. But if you can tell that they're not breathing, I would do that and then do some of the other pieces that are here. I wanted to talk a little bit about, this talks a little bit about naloxone. So what we're talking about is Narcan. And Jessica, I was wondering, do we have a policy for Narcan here? Do we have it? Are we allowed to use it?
We don't have a policy and we don't have any on grounds. We did a couple of years ago, they had trainings in Evansville, but it's been a while.
Okay.
And administering it too.
Okay. In the community, so from a community standpoint, there are a couple of locations that you can actually receive Narcan for free, because it is such a large issue that we have now. And the hospitals, Deaconess has dispensaries. They actually it's almost like a vending machine that you can get that from. And I know that Echo Downtown has where you can get that from them as well for free. There's a box. Some of the various social service agencies around town have small boxes that are on the front of their agencies that they have naloxone there, that you can get it from them for free. And it's in case of emergency. And what they carry is the nasal spray, and it's really easy to use. It is, and you can't harm somebody with naloxone, even if it's not an overdose, it's not going to harm them. That's the one of the reassuring pieces to me. So, but what it will do is it will reverse an opioid overdose. Sometimes, depending on how long they've been down, it might take more than one dose. However, if you give that to them, I mean, it's like an immediate, poof, they are backing up. So it's just a quick little nasal spray into their nose. One of the things I wanted to talk about, and I'm not sure if you guys are familiar with it. Have you guys heard about this mixture that's called Tranq? It is a mixture of fentanyl and an animal tranquilizer, and it's called xylazine. And so they are mixing these two together to get a more sustained high. And it has been going on out east, more like Philadelphia, for several years now. They've had a big problem with it for a while in Philly. And they are injecting it. And at the injection site, they're having a lot of problems with the necrotizing fasciitis. So it's like a skin eating problem that they are having with the folks that are on the street and using. And it's bad. So it's been in Indiana for about a year and a half, 2 years, I think now, that I've seen the first time that I saw anything about it in Indianapolis. And the baby that passed away last month, was on the news, that baby had that in its system. So I know for certain that it's in this area now. The thing that's important to understand about that drug is that because when they mix those two together, the tranquilizer nullifies the use of the naloxone. So Narcan will not work, because even though it's a mixture of fentanyl and this animal tranquilizer, because fentanyl is an opioid. So normally if you were taking just straight fentanyl, the Narcan would work. However, because you mix the Narcan with this animal tranquilizer with the xylazine, it won't work. You can hit them with as much Narcan as you had, and it won't work. So if somebody is taking that in overdoses, they're not coming back from it. And that's terrifying to me. So I just think that it's important for people to be aware of that. You know, and we just keep talking about the fact that you really don't know what's mixed in with your supply. So I think it's just incredibly important to be aware of what is out there and in our community.
Just to comment on that, if you aren't familiar with the Tranq drug, it's also known as the zombie drug on the streets, probably because that necrotizing fasciitis.
There's some really gruesome videos that you can look at, but I chose to leave that out. So, okay. So really we're talking addiction, and it almost becomes an automatic process. And somebody mentioned earlier that it's kind of lifelong because you have this trigger that occurs and then a thought will happen that's there, you know, gee, I really want this. The craving occurs and then use happens. Relapse prevention can only really occur if we have anticipation that's there. So, you know, that means they have to have enough education and treatment and planning, right, in there. You know, who am I going to call if there's an issue? What am I going to do for distraction? What are my triggers? How do I stay away from all of those? And so, you know, they've got their addiction, they have to have treatment and some kind of a recovery plan. So all of that has to happen that's there. Because even when you do have that, you've got those behaviors that sometimes still slip in there in the thinking. No relapse ever occurs just on its own. The relapse always starts in our thinking because that emotional building happens there, right? So either I've had, you know, a lot of the prevention that's been going on and I've got a plan in place and I stay on that path for recovery, or I have no plan and no support and I end up in a relapse. So, you know, if you are part of a support system for somebody, know what your job in their support system is, you know. For some folks, that might just be being distraction. If they call and if they say, hey, you know, I'm just having kind of a rough day, I just need somebody to talk to. Your job may be just talk to them for 15 minutes until this thought up here passes, or until they, you know, maybe they have to drive a certain route tonight because their other route was blocked. And so that the route they have to drive tonight takes them past the liquor store. Maybe they just need you to stay on the phone until they get past that. You know, maybe sometimes it's just about distraction. Other times, maybe they need you to, you know, really talk them up and remind them of what they've got to stay sober for. Know what your part in that is, you know, and how you can support them. This one, I'm going to leave this here. I'm going to send this to all of you. It's another short video. I'm not going to play it right now. It's a little drier. But he talks about how the teenage brain is primed for addiction. And what he's talking about is really interesting because he talked about his research that he did and how he discovered that how the brain molecules are set up in such a way, and that with adolescence that there is more space in between there for the learning to occur and for things to come in. And so it is set up in such a way that is perfect for addiction to slide in to. And he explains how all of that occurs. But again, it's a little dry. So I will save that and let you guys watch that. This one. Okay, so let's talk about reasons. We did talk about this a little bit, that these are the 8 primary reasons why teens tend to try drugs and alcohol. And you guys hit most of these because I asked you towards the beginning, what were some of the reasons that you thought that they did use? So if we look around at some of the stuff that's going on with our kids, you know, when we think about other people, who do you think are the other people in their lives that really impact them the most?
Their parents or their friends, but I've heard a lot of kids say that they started doing it or tried it because their parents were doing it, or they even did it with their parents.
Right. Because again, remember that goes back to that environment that they're in because they had access to it. Look at this one, popular on media. Gotta love TikTok, right? So things that they are seeing there, and not just that, the video games too glorify it. So there's a lot of glorifying that happens in songs on their short little social media platforms and video games and TV and movies. So this is a big one that's here. Sometimes we just need a mental vacation. I hear that, I can't stand what's going on and I need to numb that out. So that's a big one. You guys talked about boredom, here in the Midwest, that's a big one that's there. Rebellion. I'll show them. They think they can tell me what to do, so there's that one. Instant gratification, we talked about a lot. How about lack of confidence? How does that play into substance use? How's it going to help me?
Once they try it, they kind of lose those inhibitions.
Yep. So, it's liquid courage, right? Isn't that what we used to call it? So I need to be able to build that confidence up. And so that's what I'm looking at. And also misinformation. That is a huge one. It's, this isn't any big deal. It's not really going to hurt you, Misinformation is a really big issue with it. So some of the things that are commonly abused by our kids, so are synthetic marijuana. What are some of the names that you hear synthetic marijuana called by?
K2.
Spikes.
What else? Any others? I heard one the other day that I hadn't heard of, Udabud. I had never heard that one. So I was like, okay, you learn something new every day. Do you know what DXM is? It is, what if I call it dextromethorphan? Dextromethorphan.
Adderall.
Sorry?
Is that Adderall?
No, you're getting close. It is the cough syrup. So Robitussin. So I think that there's still some folks that use it. I've heard it like purple drink. I think I heard somebody refer to it at one point in time, mixing it with like soda and whatnot. But when I was in high school, they took it off. They took it off the shelves because the term was robing. So,
do they still? Was it lean or something?
That was, I remember that term.
They called it. Yeah. And I'll hear that occasionally. The boys will talk about it, or one of the boys will talk about it.
It's interesting, some of the things that they will mix up. E-cigs, that's a big one that's out there. The prescription stimulants. So, selling or sharing your Adderall, your Ritalin, those kind of things. Marijuana. What are some of the names that you hear marijuana by?
Loud.
Okay.
Bud, reefer, ganja.
Yeah.
Fish.
Yeah. There's, at some point I had a list from the DEA of all kinds of names, like street names for drugs. I need to see if I could find that and share, because it was really interesting to see some of them, because there were actually quite a few that I hadn't heard of. I had heard a lot, but there were several on there that I hadn't. And sometimes I think some of that's regional too. You will hear some in certain cities more than you hear it in others. So synthetic psychedelics. So this is more along the lines of like our bath salts. So there are synthetics that way. So we have fake weed and fake speed, right? So more along that way. MDMA, what's that? These pretty colored pills.
Ecstasy.
Yeah, Molly, ecstasy. our prescription pain meds, so our Percocets, our Oxys and our Roxys and all of that stuff that's there. Benzos. How about alcohol and energy drinks? Why is that even a thing? Why would people mix those two things together?
Keep going.
The upper and downer together.
Yeah,
Right.
pick you up and get you drunk.
Because I need to let go of my inhibitions, right? Like Aaron said earlier. So I'm too shy when I go to the club. So I gotta let go of my inhibitions. And then, but I got to be able to keep clubbing. So, I got to mix the two together. And opiates and opioids. We've talked about those. So marijuana in general, I just want to talk about a few of the drugs and some of the specifics. So we're talking about the flower or the plant can be smoked. So both of those, a lot of times we're putting those in such a concentrate though now too, because we hear the kids talk about dab, and when they are using it for cooking too, they're infusing it into the foods or the beverages with the edibles, the gummies, and those can be pretty strong at times. So joints, blunts, bowls, bongs, they don't even have bowls on here. So, and then vaping that's an interesting thing. We talked about that in one of our meetings where we had the one vape and testing to see whether is this actually nicotine or was this actually marijuana. And that's one of the things that's even more of a challenge, I think, for us now. It was rough enough when it was just e-cigarettes, but now what's actually in that liquid that's there, right? The compound that is actually in the marijuana that causes the high is the THC. So they can extract the cannabinoid from it and then make the concentrates for the CBD oils. And we'll talk about that in a minute. They can also smoke the oils and the racks and that they make, and that's the dabbing. CBD. So this is actually legal in Indiana, and it has been now for a few years. And what we're actually looking at is they are extracting that component from the plant. And it's only, I think that it can't be more than 0.3% THC and to be sold in Indiana. CBD is used a lot for pain, and it again can be smoked. They put it in oils, they put it in lotions, and there's a lot of different ways that folks can use that. They also put that in edibles as well for gummies. And you can also find, then you'll start to see folks with the like Delta 8 and Delta 9, which becomes a lot stronger. The problem with some of the Delta 8s and Delta 9s is we have seen folks that can be predisposed to certain things, perhaps bipolar disorder, and have never had an actual manic episode before, but it may be triggered by something along those lines. And we've also seen folks that with the synthetics that have not had problems, but then have psychosis when they're using some synthetics. And that's a problem. Somebody using marijuana, and we talked about some of these earlier, but spending a lot of time using it, craving it. So this is if they've actually got a marijuana use disorder. They are using more than they intended to. And a lot of people will say, but it's not addictive, but it is. It's absolutely addictive. And when people have the problems at home and school as a result of it, when people are using despite those problems that they're having. And when they're giving up those important activities, that's a big issue. And that's one of the signs that we are moving towards that marijuana use disorder. So we're moving out of territory of use and into the actual disorder. So needing more of it to get the same high. So when somebody smoked too much marijuana, anxiety, paranoia, panic, fast heart rate. And I think this is an interesting one because I think a lot of people don't think there is any such thing, that they don't really see that there's this. There's the two strains of marijuana that people also use. Usually you're looking at either the indicas or the sativas, and one will bring you more up and one will bring you more down. So you can have the fast heart rate, delusions or hallucinations, the high blood pressure, nausea or vomiting. So marijuana today is a higher THC level than it was back in the 60s. So you know that there's a lot to be said about the impact of development on the kids' brains that we've talked about again. E-cigarettes, going back to these. Again, things that they can be called and known as e-cigs, mods, vapes, pens, the tank systems. And what's interesting is that the Juul e-cigarettes, they all have levels of nicotine. And 2/3 of the users aged 15 to 24 don't know that Juul always contains nicotine. So thinking that, because for so long you could get just the flavored, e-cigarettes. And so they don't realize that they're actually having some that have nicotine in them. And again, it goes back to the education. We talked about that being an important piece of what's needed. The harmful substances, obviously the nicotine that's there, but those particles that you're breathing into your lungs can cause the popcorn lung issue that's there as well. And that is something that people I don't think are realizing. And we don't have all of the longitudinal studies right now to show us long-term serious impacts. So I think we're going to see more problems over the next 5 to 10 years. And I think we'll see that in younger and younger folks too, that started at such an early age because of the heavy metals that are in there. Stimulants, they speed up our body. So we can, again, have things like our amphetamines, our Adderall, Ritalin. So, and there's several that are listed there for you guys. There's also the synthetics, so bath salts that are there. Stimulants can be used in capsules. You can smoke it, you can snort it, you can inject it. What's happening is there's this sense of euphoria, but it does also, because it's used as a medication, improves that mental clarity that's there. And what's interesting sometimes is when you're working with somebody and we're looking at co-occurring disorders. So when we're looking at somebody that has a mental health disorder and an addiction disorder, almost always somebody that prefers stimulants will also have had an ADHD diagnosis as a child. Somebody that prefers either some type of a benzo or a downer or even pain pills, something that kind of zones them out, or even marijuana, they tend to have something along the anxiety spectrum. So overdose is associated with that agitation and that hostility, and sometimes the suicidal or homicidal ideation because of all of that hostility that's there. So I'm going to move us along because of time. Opioids, we know a lot about this from all of the issues that have been in the news. Here's a lot on the heroin and the morphine and all of those, but I wanted to talk a little bit about fentanyl because it's on the rise in the Midwest. We did talk a little bit about the mix of fentanyl with the xylazine, but fentanyl originally was created as a drug to help those people with end-of-life issues. So it's extremely strong. And it was, designed for folks that were in incredible pain. And so to see people using it in recreational means, it's really scary when you think about that, because it doesn't take much. We also see there's a difference between fentanyl and carfentanil. And it talks about, fentanyl is 50 times stronger than heroin, 100 times stronger than morphine. If we start talking about carfentanil is actually the elephant tranquilizer. And when they run across that, one tiny little grain of that can actually be deadly. And so sometimes if the police officers are aware or concerned that there might be fentanyl or carfentanil mixed in with something, you'll see them in there with the gear, with the masks and whatnot, because if they accidentally breathe it in, that can cause an overdose for them. Here we go back to the signs of the overdose, and we were talking about the eyes earlier. So the pinpoint pupils for opioids. The nodding off and falling asleep. We hear lots of reports of that. Anybody that watches has Evansville Watch, sometimes you'll see reports of that. The slow breathing, as somebody is getting to that spot of overdose. And we talked about some of these earlier with the choking sounds. Limp body, cold and clammy skin is another big one. These are some of the lesser known drugs that I think this is kind of an interesting piece. So ephedrine, this is one that sometimes is used as a weight loss drug, but it also is one of those that kind of speeds you up a little bit. GHB, this is a synthetic hallucinogenic that people will use. Soma is a muscle relaxant. People use this sometimes when they are struggling with their heroin withdrawal. So sometimes if they can get a hold of this, they will use this. Does anybody ever heard of kratom? It is a plant, and it came onto the scene, I don't know, maybe 4 years ago, 5 years ago, maybe a little bit longer, but more locally. I think that's about the time that I had heard about it around here. It's from maybe the Orient, I think, but you can make a tea with it. You can grind it up and put it into capsules. There's the powder that's there. It helps to relieve pain. It eases mood. So people will use that a lot for a lot of pieces, to enhance their mood and also to ease pain. Antidiarrheal drugs. I thought this one was interesting, and I had just learned about this recently, that if you see somebody with huge amounts of Imodium walking around with that or purchasing huge amounts of it, it tends to be because there are tiny amounts of opiates in Imodium. I did not realize that until recently. I thought that was interesting. And we've already talked about xylazine. Age of first use is really important, and when we're talking about addiction, because the younger that people begin using substances, the more intense that the problem is. So people that use before age 15 are 7 times more likely to develop a substance use problem later in adulthood than the people who delayed even just until they were 21 or older. That's a big difference. People who began using addictive substances, and we just talked about that one, same picture. These are some of the consequences from teen substance use. So the decline in the grades and absenteeism, we see a lot of that, but also the physical health issues. So if you're using, there's always the consequence of transmission of diseases, depending on how you're using. If you're using IV use, there's the consequence of transmission of HIV or AIDS, lots of peer-related issues and delinquency. And again, we see a lot of that with our kiddos. We talked about a little bit with the struggles with the impact on the brain. So we can have those deficits in being able to have new object recognition. So what that really means is learning new stuff and being able to get it stuck in my brain and to remember it all. So mental health problems also. If we look at the other disorders, I talked about that just a little bit. Co-occurring disorders that are going to come up. 60% of adolescents are in treatment, also meet criteria for other mental health issues. Things that come along with that are going to be anxiety disorders. So GAD, panic disorder, PTSD, also the depression spectrum and bipolar disorder. ADHD is a big one. Think about these. These are the things that people are self-medicating. Psychotic disorders, borderline personality disorder, and anti-personality disorder. Antisocial personality disorder. Trauma is a big cause of substance use because we are self-medicating. I'm going to leave this here for you guys to be able to read because of the time constraints that we have. But there are some really great articles and some great videos on the connection between trauma and substance use. And for tips for helping people in recovery, educating yourself, getting support, not only for the folks that you're helping, but for yourself. Al-Anon, Nar-Anon, get counseling for yourself so you're not running through this yourself alone. If you're involved with somebody or have family members or friends, don't enable folks, and have realistic expectations and take care of yourself. And then last is the national hotline and helpline for folks with addictions issues. So thank you guys.